Hello, everyone. Thank you for joining today's webinar, Investing in Mental Health to Support Our Workforce. I'm Catherine Martucci, Director of Policy and Programs at the Alliance for Health Policy. And for those of you who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. And I also want to acknowledge before we get further that, especially given the topic of today's event, that we are getting reports of an active bomb threat at the Library of Congress in Washington, D.C. And so we know that this is potentially distracting to those of you who live and work in D.C. or those who have friends, family, colleagues here. So we hope that everyone stays safe, and we are keeping all involved in the response and our thoughts. And I also wanted to say that this event is part of a broader series exploring the economic impact of COVID-19 at all levels of government, and exploring links between workforce productivity, coverage, and population health, as well as examining short and long-term policy implications. So want to thank our signature series sponsors for supporting this event, as well as a summit that we held in June. And I also want to remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive, and join our community at AllHealthPolicy, as well as on Facebook and LinkedIn. And we want you to be active participants in the conversation today, so please get your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark, and you can use that speech bubble icon to submit questions you have for the panelists at any time. We'll be collecting these and addressing them throughout the broadcast. You can also use that chat to chat about any technical issues you may be experiencing as well. And then finally, please be sure to check out our website, allhealthpolicy.org, where we have lots of background materials on this particular event, as well as the series, the signature series that I just mentioned. So speaker bios, resource lists, expert lists, and then a recording of today's webinar will be included there, as well as the slides. And then our Health and the Economy Summit, we had over 5 or 6 sessions, lots of really interesting conversations, so definitely encourage you to check all of that out as well. And now I am so pleased to introduce our esteemed moderator, Ms. Kana Inomoto. Kana is a senior expert at McKinsey & Company, where she specializes in behavioral health, public health, and delivery system reform. And she has more than 20 years of experience as a federal executive in mental health and substance abuse policy, data, programs, and practice improvement. And prior to joining McKinsey, Kana was a senior advisor and acting chief of staff to the Surgeon General of the United States, as well as acting administrator for the Substance Abuse and Mental Health Services Administration, or SAMHSA. And she recently co-authored several publications for McKinsey evaluating mental health in the workplace, including approaches to overcoming stigma and strategies to creating a psychologically safer workplace. So very pleased to turn this conversation over to a true expert. Kana, thank you for joining us today. Please take it away.
Wow, thank you very much, Catherine, and thank you to the Alliance for hosting this event today and for having me here. I'm super excited to have the conversation because, as we all know, in the era of COVID, mental health has really come into its own as a central organizing force in the lives of all Americans, whether that's at home, in school, or at work. And so as the pandemic evolves, and return to the workplace continues in fits and starts in different parts of the country, many people in our workforce are perceiving gaps in the support that they're receiving from their employers, and employers themselves are struggling with knowing what to do. And so I think this conversation today will be extremely important and illuminating for those of us who are scratching our heads and thinking through what is the best path forward to support our folks, because our survey data show that 9 out of 10 employers are saying that COVID has affected the mental health of their employees, and in turn that is affecting their productivity and their engagement in the office, and so, or at the workplace. And so this is a super opportune time, I think, to have this conversation and think about the data and the findings that we're seeing about what really works for people. Because with all the disruption we've experienced, not just COVID, but everything else in the last year and a half, it's just more important than ever to support business leaders and their role in taking care of their employees and thinking through how do we prioritize mental health as part of health, and how does that in turn create an opportunity for our businesses. So I'm very fortunate to co-lead the Center for Societal Benefit through Healthcare, and just wanted to share a couple of data points that we're seeing and before we dive into our presentations. So if we could go to the next page. Thank you. So here, as I mentioned, we're seeing that employees are struggling with mental health challenges, and employers are quite aware of this, that 1 out of 3 employees are saying that burnout is one of their top challenges during the pandemic, that 4 out of 10 employers are appointing someone to focus on behavioral health in their companies. And we know, we're probably not doing enough there, because we know that's an important strategy for employers that want to make good progress in this. 3 out of 4 employers say they're making progress in the space, and that they are reporting challenges with how to do this better. And our employees are saying that, even though my employer is investing, we're still having a hard time. Those of us who need services are having challenges accessing them. And only 1 out of 4, pretty much, frontline employees say that the employer offerings in behavioral health are good or very good. Right, so we have a ways to go, and hopefully in today's conversation we'll get some ideas for how to get there. Next page. And I think we've seen, actually we've had some pretty good traction on these data, that 1 out of 3, essentially 1 out of 3 employees who have returned to on-site work are saying that that has negatively impacted their mental health. And there are some variation across populations. So Gen Z, younger people who don't have children, are seeing a more positive impact. People who do have children in their household are feeling more stressed about it. People who already feel anxious or depressed are more stressed by going back to work. In other data, we've seen that women, in particular women with children, Black women, are really feeling the pressure, and senior women as well have felt more pressure during this time, and that return to work is particularly challenging in terms of being able to balance the responsibilities that they have in both places, as well as some concern about losing the flexibilities that they had gained during COVID. So those people who are feeling the negative impact are 5 times more likely to say that they're going to take reduced responsibility at work. So this is obviously of interest to all of us as we think through how to navigate this process of returning to work. Next page. And so with that, I am excited to bring this back to our panelists and introduce you to our first speaker. Their full bios, all of our speakers today are esteemed experts. Their full bios are on the Alliance website, but I want to do them justice and briefly introduce them. So I'm first joined by Dr. Beth McGinty, Director of the Center for Mental Health and Addiction Policy Research at the Johns Hopkins Bloomberg School of Public Health. In addition to her directorship, Beth is also Associate Professor and the Associate Chair for Research and Practice in the Department of Health Policy and Management. Next, I'm pleased to introduce Mr. Jonah Cunningham, Government Relations Manager at Trust for America's Health, where he focuses on behavioral health issues and ways to reduce mortality from substance misuse and suicide. And prior to joining TIFA, Jonah worked for over 6 years on the staff of Representative Grace Napolitano, a great champion for mental health and mental health services. And finally, we're joined today by Ms. Shatrain Burble, Vice President of Government Relations at HR Policy Association, where she leads the association's government relations strategy on topics such as benefits, diversity, inclusion, labor, safety, immigration, and compensation. Just a little portfolio there. And prior to this role, Shatrain was Vice President of Public Policy for the Society of Human Resource Management. So we're going to start today's discussion hearing from Dr. McGinty, who'll provide some overall context on how our nation's mental health has been changing. So Beth, I turn it over to you.
Great, thanks so much for the introduction, Kana, and for teeing up our focus here today. So as you say, I'm going to start us off with some introductory context on what we know about mental health and how it's evolving during the pandemic, and in particular, think through some of the research on the drivers of elevated symptoms of distress, anxiety, depression during the pandemic, and that what we know about those drivers can provide some clues into how we might support mental health in the workplace moving forward. Next slide. So I'm going to ground my introductory remarks in some data from our team at Johns Hopkins. We are just now finishing up actually a longitudinal survey of a cohort of about 1,500 US adults ages 18 and older. And we've surveyed them 4 times, starting in April 2020, and actually the last wave, which I don't have data for, just came out of the field yesterday. So I'm going to show you what we know about mental health in a nationally representative sample of American adults at 3 time points so far. April 2020, so the very beginning of the COVID-19 pandemic, July 2020, and November 2020. And as I said, stay tuned for a similar battery of measures from August 2021. So what you see on this first slide is the prevalence of serious psychological distress, which is a validated measure that gets used quite a bit in the public mental health world that captures a series of individual measures related to symptoms of anxiety and depression. And this measure of serious psychological distress has been validated against clinical diagnoses of mental illness and is shown to be predictive of people having clinical diagnosis and sort of significant interruptions to their life as a result of their mental health symptoms. Typically, the prevalence of serious psychological distress among US adults, which is measured every single year in the National Health and Review Survey, is about 4%. Between 3 and 4% of US adults for the last 20 years pre-COVID-19 met criteria for serious psychological distress. Our data shows that during the pandemic, between 13 and 15% of US adults met this serious psychological distress criteria. So the prevalence more than tripled during the pandemic. Next slide. So I think the logical segue from those data points about we're feeling a lot more distressed as a society is, well, what are the drivers? And of course, there are many drivers, not a single one during the pandemic, but we have done some work to explore what some of them might be. So one common issue that's brought up in the context of COVID-19, given the role of social isolation as a mitigation strategy in terms of preventing the infectious disease, is loneliness. Are people socially isolated? Are they lonely? Is that part of what's driving distress? And what we find here is that loneliness has also increased during the COVID-19 pandemic, but it has not increased to the same degree that psychological distress has increased. So that suggests that loneliness is one, but not the only factor driving these increases in distress. Next slide. Another potential driver, of course, is fear of the virus. And so the way that we looked at this data point and the next few that I'm also going to show you is we asked people in this nationally representative sample of adults about a whole array of factors that they reported have adversely affected their mental health in the past 30 days. And then we compared the frequency with which people mentioned a given factor, like fear of the virus, excuse me, among people who had serious distress versus people who didn't. And so what we found, what this slide shows, is that people who were experiencing serious psychological distress were significantly more likely than people who weren't to report that they had concern about me or my family members contracting COVID-19 and that concern was adversely affecting their mental health. Next slide. Using that same technique, comparing drivers of self-reported adverse mental health in people with versus without serious distress, we found that folks who had serious distress were much more likely than people who did not to report that they were worried about their ability to obtain health care and about the adequacy of their healthcare insurance. Of course, job loss from the pandemic affected many people's health insurance, and multiple aspects of the pandemic, including that health insurance loss, as well as health system disruptions, have influenced access to health care. Next slide. Employment and finances is a big one. So you see major differences in the bars on this graph between people with versus without serious distress. And those experiencing serious distress, I think not surprisingly, were much more likely to report COVID-19 related disruptions to their employment and to their finances. Next slide. Education is also a big one, particularly for young adults. I didn't show this data point, but our research and other studies that are out there have shown that the adverse mental health effects of the pandemic have been really particularly elevated among young adults. And one potential driver of this is disruptions to education. And so that is very much borne out by the data shown here, and that people with serious psychological distress who reported that they were pre-pandemic planning on engaging in some further education reported that their ability to attend school or college was adversely affected by COVID, and that adversely affected their mental health. Next slide. So there are, of course, other drivers of declines of mental health during COVID-19. I could, show you graphs that look like that all day on a huge range of factors. Some other big ones that have been shown in studies conducted by other researchers outside of our team include childcare, of course, and other caregiving challenges. For folks who have been doing work deemed essential throughout the pandemic, healthcare workers and others, there are enormous stressors associated with that essential work. Certainly, uncertainty about the future plays into many people's reports of increased psychological distress during the pandemic. And, the pandemic has not occurred in a vacuum. We have, in particular, experienced many co-occurring stressors related to racial justice, the killing of George Floyd, and other incidents co-occurring with the pandemic that are also shown in other research to be important drivers of distress. The data that I showed focuses on adults, but just a note that we certainly see similar increases in anxiety and depression symptoms among youth, who in some ways are perhaps less relevant for our topic today of sort of workforce mental health, except that, of course, youth are the future workforce. So we should be thinking about them in the long run. And final slide. So in terms of sort of what we know about this data and what it means, I often get asked, well, like, what does this mean for sort of the long term of mental health? If the pandemic resolves, are we going to see sort of long-term adverse mental health consequences? And the straight answer is we just don't know yet, but evidence suggests that being a very real possibility, in that acute distress is known to transfer to longer-term psychiatric disorders or exacerbate existing mental health conditions. And many of the drivers of psychological distress, the economic and financial drivers, other socioeconomic drivers, these may take quite a while to resolve for many people, in that we're certainly still seeing them in our society now. And even if we were to get the pandemic under control tomorrow, certainly shifts in the economy and household finances can be longer lasting. And in terms of thinking about implications for the workplace, I'll largely hand that topic off to my fellow panelists, but I would just perhaps tee them up by saying that, this data suggests that it's really important to think about both mental health focused services, right? Wellness and referral and coverage to clinical mental health services. But also, we're seeing much of distress being driven by employment and income related challenges and fear around job loss. And so the work environment itself is really very important in terms of addressing mental health and preventing further adverse consequences moving forward. Thanks very much.
Thanks so much for the helpful context, Beth. Now I'm going to turn it over to Jonah, and we're going to try to stay on time if we can. Thanks, Jonah.
Thank you, Kana. So I'm Jonah Cunningham from Trust for America's Health, or TIFA. We're a small think tank with an advocacy arm here in Washington, D.C., and we really focus on public health issues. So to start off, you can go to the next slide. I thought it'd be helpful to kind of review the role of the federal government when it comes to mental health policy. Now, we all know health policy is really complicated, and mental health policy even more so, with the role that the state and local governments have on providing services. But there are basically 5 major buckets the federal government does. Probably the most important is federal funding and technical assistance. Now, the 2 largest programs administered by the Substance Abuse Mental Health Services Administration are the Mental Health Block Grant and the Substance Abuse Prevention Treatment Block Grant. Those are a lifeline to states. But the federal government also has various regulations and protections, most notably mental health parity for private insurance, disability protections, and regulations surrounding service provision. The federal government also engages in research and surveillance. For example, the National Institute of Mental Health does a lot of research on the precursors of mental illness, suicide prevention, and of course, there's important surveillance systems like the National Survey of Drug Use and Health. And of course, the federal government does do insurance coverage for older adults through Medicare, and actually the largest payer for behavioral health services is Medicaid for low-income adults. And lastly, provide services to some populations, most notably veterans through the VA or those in the Department of Defense. And we can go to the next slide. So now that we know kind of the levers and the responsibilities, I just wanted to identify some agencies and departments that also engage in mental health policy. You can argue all federal government and all government in general indirectly affects mental wellness, but really wanted to hone in on a few here. So I already mentioned the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the state block grants. But they also do technical assistance and grant programs to school mental health. Again, as Dr. McGinty mentioned, children are the future workforce. Then there's the Centers for Disease Control and Prevention, specifically the Injury Center, which does a lot of surveillance, both when it comes to violence, adverse childhood experiences, opioids through prescription drug monitoring programs. HRSA does a lot when it comes to workforce development and workforce development grants. The Centers for Medicare and Medicaid Services does a lot of innovation around payment measures, quality measures. And then outside of the Department of Health and Human Services, the Department of Labor enforces mental health parity law, And the Department of Education does a lot with social emotional learning. We can go to the next slide. So as Dr. McGinty mentioned, COVID-19 has had a massive effect on the population, basically every aspect of society. And the federal government has had a widespread response as well, through increased flexibility for providers, specifically for telehealth, which is vital for mental health for those that might be suffering from mental distress. To be able to connect with a therapist or psychologist is critical during these times. They've also invested heavily in what I'll call the social determinants of health, or the social determinants of mental health. So these are things like paid sick leave, child tax credits, the Paycheck Protection Program, unemployment insurance, kind of precursors to that really help prevent anxiety, especially around finances, help alleviate concerns about childcare, etc. They've also invested in existing programs. They've scaled up the state block grants for mental health and substance abuse, and also established some new ones as well, like the child tax credit. And lastly, they've also really beefed up surveillance and research, both when in regards to mental health, but then also the interaction between COVID-19 and mental health. And we can go to the next slide. And I thought it'd be kind of helpful, now that we know the policy levers, we know the agencies involved, we know a little bit of the reaction to COVID-19 and some of the investments the federal government's done, to really highlight some possible opportunities. Now, first and foremost are continuing the new programs and funding and flexibilities. I mentioned telehealth, but there is also a lot of flexibility when it comes to those who have a substance use disorder. In particular through take-home doses for medically assisted treatment, either methadone or buprenorphine. There's also a huge opportunity when it comes to the 988 transition. Now, to kind of back up, for the Suicide Prevention Lifeline, which is 1-800-273-8255, there was a law that passed that would create a new 3-digit number, not only for suicide prevention, but for mental health crisis. And by July of 2022, this will go live. Now, this is a huge opportunity, but requires investment not only at the federal level, but state and local governments as well, and could radically change how mental health crisis is responded to, making it a health issue, not typically what's been a law enforcement issue. Now, the third one I wanted to highlight, the continuous surveillance of trends. It's not the most sexy topic, but it's critical that we understand the effects of COVID, the effects of the pandemic, the effects of policy, and also connect it to ways to address them, to alleviate some of those concerns, and look at different interventions that we could do. And lastly, and this is my own prediction, there's a lot of opportunity when it comes to novel interventions. A lot of these can supplement the current workforce shortage and things like peer support, mental health first aid. And there's an emerging trend called community-initiated care, where you train laymen to do basic supportive services. And I expect this trend to continue given the long horizon, the long amount of time it takes to train up psychologists, therapists, and psychiatrists. So we will see it as time goes by. And with that, you can go to the last slide. I'd encourage you, if you have any questions, feel free to email me. You can also look up our Pain in the Nation report, highlighting the trends of the deaths of despair, so suicide, substance use, and alcohol-related deaths, at tifa.org, or follow us on Twitter at HealthyAmerica1. And with that, I'll hand it back over to Kana.
Thank you so much, Jonah. I love that Pain in the Nation report. It's so informative and super useful. So I'm going to turn it over to Shatrain.
Hi again, everybody. My name is Shatrain Birbal. I'm Vice President of Government Relations at HR Policy Association. HR Policy Association is a membership organization for the Fortune 500 companies in the United States. We have members that have employees in the United States and also globally. My conversation today is really going to focus on what are employers doing in response to COVID-19, and what and how have they already invested in the overall well-being of their workforce and the mental health of their workforce. Next slide, please. So I know Dr. McGinty went through a lot of really great data points. I would be remiss if I did not mention that HR Policy Association and our American Health Policy Institute is a collaborator with several other mental health groups like Total Brain, One Mind at Work, and the National Alliance for Mental Health. And as such, as a partnering organization, they put together a mental health index. And my next couple of slides here are going to focus on the findings of our mental health index since the pandemic, and we're going to even have a look at some of those numbers pre-pandemic. Next slide, please. So this slide really just shows the COVID-19 impact, the timeline, and kind of like the high points in where we were seeing greater response as it relates to mental health. You'll notice that the dashed line here is signifies an individual with no history of anxiety and depression. The solid line is for those with pre-existing anxiety and depression. And you'll just know, I think Dr. McGinty already outlined this, and it's pretty consistent that even individuals without a previous anxiety or depression diagnosis is also greatly impacted by the pandemic. And I think we can skip forward to actually slides 5, because I think Dr. McGinty covered a lot of the metrics, but I only included these other data points in case if those of you are interested in seeing what the workforce data points were showing, which again are very consistent with Dr. McGinty's team's findings. So workplace resources and the ecosystem of support. Employers have long invested in the mental health and overall well-being of their workforces. There was a report, the Mental Health at Work 2019 report, this was prior to the pandemic, which had indicated that employers were already making some significant investments. They were implementing mental health training in the workplace. They were providing a little bit more information in terms of what resources were available to employees, and not just resources, but what are the benefit offerings and how can employees access those benefits. As Dr. McGinty mentioned at the outset, sometimes employees they may know that their employer offers these benefits, but they might not have knowledge on actually how to access the information or access the benefit. In addition to that, employers were focusing on initiatives that encourage a positive workplace culture, encourage a culture where one can come forward and talk with HR or their colleagues or their supervisor about any work accommodations or any benefits that they might need to be helpful to them. Next slide, please. Since the pandemic, we know that many employers have shored up their benefit offerings. This slide just shows the gamut of various benefits that employers have expanded to provide more access to mental health resources, mental health and behavioral health resources. I wish I could take credit for HR Policy Association being able to put together this slide, but this slide, I found a great article from Business Insider that highlighted the various companies and different initiatives that they were undertaking to support their workforce. So I cannot take credit, but I have provided the link on this slide to the actual article with more information as it relates to these programs. Next slide, please. The Business Group on Health, this is a group that commissions a research every single year on the types of benefits that employers provide to their employees. And I am very happy to report here that for 2021, the number one, I know I have number 4 on here, but the number 1 investment that employers are making, large employers are making this year in particular, is that of its health and well-being role in its workplace strategy. What that means is this year, more than ever before, employers are investing in the health and well-being as part of the integral part of their workplace strategy. This has increased actually from previous years, from 36% in 2019 to 45% in 2020. We believe that this is in part spurred from the COVID-19 pandemic, which is shedding a light on the connection between employee health and well-being and the overall business performance. So that was item number one, the investment in health and well-being as part of the workforce strategy. The number 4 item was mental health remains in the spotlight. Again, as I mentioned before, many employers were investing in the mental health of their workforce prior to the pandemic, but now they are even pouring in more resources. And my slide here shows where those resources are. And I know we'll get into more specifically of the various benefit offerings and resources that employers are offering in the Q&A segment. So I'm going to stop here as my formal presentation. I'll turn it back over to Kana.
Thank you so much, Shatran. It's really great data and exciting to see so much energy behind the work you guys are doing. And appreciate you leaving some to the imagination for our audience to ask questions. We'd love to hear from folks who are with us today. And please remember, you can use the questions panel of the audience interface to submit your questions at any time. So while I see we already have some questions, and I welcome all of you to go ahead and populate the queue. And we're going to start with an opening one. Employers clearly need to do a lot in terms of messaging, demonstrating in word and deed that mental health is health. What specific actions should employers take? So maybe we could actually start with Shatran on that one.
I'm sorry, Kana, can you please repeat that? I was getting an alert from the system here.
Okay. So employers need to do a better job in messaging, demonstrating in word and deed that mental health is health. So if you could just describe some specific actions that you think employers should take to communicate this priority.
Sure. So what we're already seeing is, employers traditionally during open enrollment, they'll send out a ton of information in writing about the benefit offerings. What we're seeing more and more of is employers are actually using various platforms to communicate benefit offerings and to facilitate more conversations regarding overall well-being, behavioral health, and mental health. In the midst of the pandemic, many groups are using Teams, Zooms to communicate, and as such, we are seeing more and more HR professionals utilize those tools to create a channel to discuss various topics that the workforce is dealing with, especially in this remote environment, and still trying to keep that connection. I've heard of some groups using those, different platforms to convene coffee check-ins, to convene sessions where employees have the opportunity to chat about things that are concerning to them, whether it be about their workloads or childcare, or perhaps even dealing with the death of a loved one in part due to the pandemic. So employers are using these other platforms in response to how their employee or their workforce is communicating. We all know the workforce is very diverse right now. It's the most diverse workforce with 5 generations in the workplace. And so employers are really taking a very close look at their specific workforce and tailoring their messaging in the way that they're communicating based on the demographics of their specific workforce.
Awesome, thank you. Thank you very much, Shatran. Okay, so our next question is for Jonah. Jonah, would you please explain more about community-associated care?
I will try. Since we're a public health think tank, we look more outside of the clinic. But Beth, were you raising your hand to tag team? No, okay, I was with a shot. But community-associated care, basically trying to outpatient treatment. I guess I can go in the history a little bit where prior to 1960, there was the institutionalization. That's where a lot of people were treated. They were warehousing individuals. And we've been trying to build up this outpatient since the deinstitutionalization in the 1960s. JFK was going to get involved. Fortunately, he passed away. And then it basically spawned into the block grants, the 2 block grants I mentioned, the Substance Abuse Prevention Treatment Block Grant and the Mental Health Block Grant. Now, community-associated care, I assume you're talking about outpatient care, correct? It's really important to build that up, but it's also the spectrum of care. We've seen a lot of workforce shortages, where over a third of Americans live in an area that that's designated by HRSA to have a mental health workforce shortage. So that means we have to supplement that some way, shape, or form, whether it's through community interventions, therapists, mental health first aid, community-initiated care, things like that. But hopefully that gets to the crux of the question.
Mm-hmm. I think so, and I would just add to that that I think what you're getting at is that we're moving sort of out of the history of the psych hospitals, right, and even general hospitals, right, like keeping people out of the emergency department, out of inpatient units, but really getting services where they live, work, play, go to school, and using the lowest level of intensity and like least restrictive environment that would be suitable for that person. I think that's the idea, to get services that are really framed around the individual and their family and what's going to be the best to help them meet their personal goals in the community. So thank you for that. And then the next program is also about, can you tell us more about the program to train lay providers in mental health services?
So there are a few different programs to train. There's the workforce development piece, and HRSA has 2 different block grants, the mental health workforce development, or not block grants, the mental health workforce development program, as well as for substance use providers. But then there's also ones that provide technical assistance, like the National Child Traumatic Stress Network, which provides trainings to healthcare providers, administrators, to really not re-traumatize children. And there's also a host of technical assistance as well that SAMHSA does, whether it's through the INNED, the national network to eliminate disparities in behavioral health, to make sure that treatment is culturally and linguistically informed. So there are a number of efforts located throughout the federal government, I guess, is this thesis, where SAMHSA, HRSA with the workforce development, even CMS with some guidance and what services can be provided. But the one I would really highly recommend looking into, and Kana can speak a little more to it as well, is SAMHSA's work in providing technical assistance.
Yeah, and I think, and others, I'd welcome you to jump in, but I would just add that, when we talk about lay people, it's not necessarily to train them to become clinicians or to act in lieu of a clinician, but as a complement. So like we have community health workers, we have promotores on the healthcare side, community health side. We have people who can be recovery coaches, family support workers, recovery support workers, peers, as well as simply behavioral health workers who are maybe speak a different language or are familiar with a particular community, and sort of are located closer to where people are and are able to provide those wraparound supports for the daily kind of navigation and support of the system, that you don't really need to have a licensed independent practitioner to do. And so that allows everybody to practice at the top of their license and for people to get, I think, a richer level of support. And we're seeing this in that grandmothers and aunties in Africa and India, as well as in the UK, are participating in these types of stepped care models. And we have it obviously in the United States as well. Beth, did you want to jump in?
No, just to say that I agree with that characterization. And I think to amplify one of the pieces you just alluded to, kind of one model for this that I think has particular appeal to many is the sort of peer element of this, where people with lived experience of mental illness or substance use are involved in helping to navigate care and provide support and play sort of a variety of roles that many people find very helpful and destigmatizing.
Yeah, 100%. And even in the workplace, this also plays out. Like I have a daughter that struggles with her mental health and has had a lot of challenges. And so at my workplace, I'm part of a parents of children with special needs. And I find that an incredible source of support and resources and ideas. And so, sometimes it's just helpful to talk to somebody who's kind of walked in your shoes, and can kind of give you those shortcuts and those tips and the support that fits the context where you are. So I think this is relevant to employers as well as folks who are working out in community services. The next question, Jonah, go ahead.
I was just going to add on just a little bit too in the workforce, and I'm partial towards peer support. My brother's a firefighter and is head of the peer support program for the fire department at Salt Lake City. So it's not only it's traumatic events on the job and talking to someone that's a peer and able to support you and help alleviate. He explained it as like 3 levels, right? First is the guys around the table, your crew. The second level is peer support, and the third level is the department psychiatrist. But it can really help provide supports in the workforce.
Although that's a pretty big jump between your peer firefighters and the psychiatrist, but I'm sure it's an evolving model. So, okay, here's another question, and this is for all of you. Beyond increasing and adding benefits, do you have recommendations for how to incorporate mental health or mental wellness into organizational culture, specifically across the workforce, not just from the top down? So how do we incorporate more mental health promotion, I would say, into our organizational culture?
I'll start us off, Kana. I think that's a great question. First, I would say, mental health is not a one-size-fits-all approach. As Dr. McGinty was walking through about the various reasons of why individuals might have are currently suffering from mental health issues or anxiety, is employers and within the workplace, there needs to be an understanding that your workforce is diverse, and as such, many of the issues or the way in which we respond to mental health is going to be very different. DE&I has to be part of that conversation because many people will deal with the situations before them differently depending on their backgrounds, their upbringing, experiences, what have you. And so, employers I know already are integrating a lot of this into those conversations by facilitating different dialogue, different resources, depending again on the demographics of their specific workplace. So I think I wanted to highlight that point. The other is many employers have embraced trying to find unique ways to talk about mental health in the workplace, recognizing again that there are some negative stigmas associated with mental health, and trying to break that down and show that really mental health is part of your overall health. So it's organically having some of those conversations within the workplace without it being sort of a flashing sign that says this is a mental health conversation or seminar. So employers are implementing other creative ways in helping to have those conversations without stigmatizing it even further. And I'll stop there.
Awesome. And Beth, from your research, are you showing kind of protective factors or promotive factors? We've seen things that are driving distress. Do we see factors that are driving wellness?
Yeah, it's a great question, and not something that we have focused on, and I think a gap in the work more generally. There are broader bodies of research about sources of resilience here, but I do think there's a real need to think about this in this specific moment where the world is changing so rapidly. What are some of those specific workplace related supports that are reducing distress? just to build off the conversation a bit here around sort of the importance of thinking about in the workplace ways to promote mental health and sort of encourage conversations about mental health. That sounds like a simple thing. It's much easier said than done, I think. And I really just want to sort of elevate the importance there. You want to get to a place where people aren't afraid to say to their supervisor, I need to take a sick day today, because my anxiety is really flaring up, the same way they would in like I have a stomach bug, without even thinking about it, right? Which just doesn't happen very often now. And so that's sort of the goal to get there. But in terms of how to get there, I think having leadership who really emphasize that they take mental health seriously and that they understand that, mental health and physical health are not really separate things. They're all part of our health and well-being, and leadership who are willing to talk about their own mental health and sort of model that. I took Friday off because I was having a challenging mental health day kind of thing, I think really makes an enormous difference in terms of culture.
Yeah, and I would add to kind of, I've worked for organizations in the past where my direct bosses would take a mental health day at least once or twice a month. I think once, employees see that their own leaders are not just talking the talk, but actually walking it, that will incentivize them to think that, hey, it's okay if I do that. Because I think that aside from the stigma being associated with mental health based on your diverse background, there is also a stigma associated with, are you particularly weak, or unable to perform your job because you're admitting that you are suffering from anxiety or depression or anything like that. So I think if we in the workplace as employees see someone that is a role model in our workplace that is taking care of themselves and leading by example, I think that goes a long way.
That's such a great point, the leading by example from you guys. In one of our surveys, we found that only 1 out of 10 employees feel that their workplace is stigma-free. So almost everybody experiences or perceives some level of stigma, and yet kind of anti-stigma efforts are kind of the lowest on employers' priority lists. Understandably, there's a lot to catch up on, so I don't necessarily fault them for that, but we do need to help people understand that, and I think one of our audience members said mental health is health, and that people can feel as free to talk about their mental health issues as they do their other issues, or to not talk about it, right? Someone said, well, this person's coming back from a mental health leave, how should we address it? And I was like, well, how do we address when they come back from a physical health leave, right? Like, we don't actually need to announce it to the team that someone is coming back from, an OBGYN procedure or GYN procedure. So we certainly don't need to announce that they're on, returning from a mental health leave. And yet that person should feel as free as they would like to disclose if that's what they want to do, right? So health is health, and mental health is part of that. So I guess I want to, we're talking a lot about COVID and how COVID has exacerbated things, but I wonder, maybe Joni, you could talk to us about, these aren't necessarily new problems, right?
Yeah,
so what would you say is, describe the trends pre-COVID?
So even pre-COVID, we've seen a lot of increases in the deaths of despair. Obviously, what you measure will indicate different things, right? But we've seen suicide, alcohol-related deaths, and substance use-related deaths, like opioids, increase over the last decade. And even prior to in 2019, substance use deaths increased 5%. The one bright spot was in 2019. Suicide decreased 4%, and hopefully that trend continues. But we've had this issue about not only connecting individuals to care, but for the last decade, for whatever reason, and I know there are a lot of different theories, there's whether it's workforce, whether it's changing demographics, whatever it may be, lack of access to care. But we've seen this, and some of the early indicators are COVID exacerbated it, where the preliminary overdose numbers show over a 30% increase in substance use related deaths. And of course, those numbers will be finalized later this year. But really concerning trends, and we've seen increases to the Suicide Prevention Lifeline early and during the COVID pandemic. So it's, this pandemic already hit a mental health and substance use epidemic, and there are some really concerning trends.
Yep. And just adding to the deaths of despair, that there's actually 3 major conditions that are contributing to those, and chronic liver disease gets overlooked a lot. But what we're seeing in chronic liver disease affecting younger and younger people is really startling. And so the need to address alcohol misuse, which continues to be the number one addictive substance, is very pressing. And so I'm going to finish with a question about how we can address the needs of specific populations, vulnerable populations. So older adults, people of color, people in rural areas, they are struggling with some distinctive issues and maybe less comfortable, less excited about going back to the workplace, whether it's because of fear of catching COVID, or relief from microaggressions, or relief from long commutes, or lack of access to other resources. What would you guys, I'll just go to each of you, and if you have a thought about what we can do to better meet the needs of diverse populations. Shatrain, would you like to start?
Sure, I can start off. So the employer community, we are advocating for a number of legislative proposals and regulatory changes to help expand access to care. One is we'd like to see more, behavioral health providers, in particular in rural areas. So we are working to see if we can expand the network of providers to reach those areas. And that is also inclusive of more diverse behavioral practitioners, because we do believe that will help to encourage underrepresented populations to seek care if they have someone that they feel that they more relate to. We are also advocating for more telehealth advances or telehealth access, in particular for those individuals that have high deductible health plans. So there are a number of legislative proposals we're also advocating for that will allow individuals to be able to afford and have more access to care. But I think the biggest one is more access to providers or practitioners.
That's a great point. And actually, just being mindful of time, I'm just going to ask for like a 20-second speed round for Beth and Jonah to just give us your kind of parting words for our audience today.
Yeah, I can do that real quick. So, I think that one sort of lesson for me, I'm really just sort of relating to your last question around, vulnerable groups, is sort of worker-informed flexibility. We're talking a lot about flexibility, but different people need different types of flexibilities. I'll close with just a very simple example, which is that on my own research team, I have one person who felt that her mental health would really be improved if she were able to go into the office a bit more, because she was working in close quarters at home and had some stressors there, and so she really wanted to go into the office more. And I had another person on my team who really felt like continued flexibility to avoid an onerous commute was going to be, and like facilitate some childcare issues was going to be the most helpful thing for her, right? So there wasn't sort of a one-size-fits-all solution there, and I needed to listen to them in order to figure out what would help.
Awesome. I love that worker-informed flexibility. Jonah?
I'll just quickly say, think locally, act globally, where think about the people around you. These trends are concerning. They're probably affecting someone you know, someone you love, a family member. Just reaching out to them, connecting with them on the level, listening to their concerns and trying to support them. But then also, if you work in health policy, or if you want to advocate for it, getting involved, talking to your local member. There's obviously 1,000 different pathways, but making sure that your voice is also being heard and supporting not only your loved ones, but also your own needs as well for mental health.
Awesome. Thank you, guys. That was really well stated. And appreciate everyone's insights on this topic today and the great questions. This has been a really robust conversation. I'm asking our audience to please take time to complete the evaluation survey that you'll receive immediately after the broadcast ends, as well as by email later today. And please think about joining us again on August 25th from 12 to 1:15 for a webinar on COVID-19 vaccine confidence in geographic areas of need. And also August 31st from 12 to 1 for a webinar on Medicare payment reform. And then September 15th and 16th for the second signature series summit focused on health equity. So with that, I will hand it over.
Thanks, Kana. Yep, we can now end the webinar, and thanks everyone for joining, especially the speakers.
Thanks.